have four wonderful panelists. This will be a conversation led by Dr. Mick Connors, the founder and CEO of Anytime Pediatrics. We'll also have a presentation by Rebecca Ohlinger. She's the manager of virtual care at Omaha Children's Hospital and Medical Center. Followed by Indira Modh at Adjuvant.Health, affiliated also with Allied Physicians Group, where she is the Director of Analytics. And then we'll have a great presentation by Dr. Russell Libby, who's a pediatrician, the president and founder of Virginia Pediatric Group. So at this time, I'll turn things over to Dr. Connors. Hi, Mick.
Hey, Tencel. Thanks. As always, for getting this together and kind of organizing this. I really appreciate everyone who's attending and who will watch the recording. I think it's, been about a year since kind of COVID hit, and the pandemic has kind of changed everything in virtual care. And it's actually great to do a webinar on quality and telemedicine, because I think if I talked to most pediatricians before COVID, they would say that telemedicine was bad medicine and we'll never do telemedicine and the like. So I think it's kind of a fun proposition, but also a difficult proposition when you talk about, anytime you talk about quality around anything. So I like this aspect of quality discussion. Certainly opened my eyes when I did pediatric sedation, when we thought about, gosh, is just getting a procedure done and holding a child down, is that a quality experience, or are there other definitions around quality? And I think the same is true around telemedicine or any care that we deliver. And I think it's especially interesting today, and happy to have Rebecca, Indira, and Russell with us, because I think quality is a matter of perspective. So we'll get hospital perspective today, we'll get a pediatrician's perspective, and we'll get a large supergroup perspective on how they look at quality and how they define quality. So we often in medicine talk about the quadruple aim, is that the ultimate measure of quality? So improve population health, satisfied providers, reduce care cost, and certainly satisfied patients is often at the center. We can talk a long time about what patient satisfaction is and means related to quality. We also are often very familiar with the Institute of Medicine and the 6 aims of quality. So we're talking about it being safe, effective, efficient, equitable, timely, and patient-centered. So, it's just not a one-off. There's not like, hey, that was a great experience, or I got the antibiotic I wanted. There's multiple components to quality, and we really have to begin to kind of dissect it and think about it, in much broader terms. I think it's always interesting too, as we physicians, we all think when we deliver the highest quality of care. And then the question is, well, do you? And how do you measure that? And how do you kind of prove that out? So I know, certainly all of us look at this differently. So it's really important to begin to kind of think about it a little more scientifically. Next slide. So this is an interesting study, an article that is coming out of Sprout, and Dr. Libby will talk about this later. But so you have kind of the quadruple aim, you have the Institute of Medicine, and Dr. Chow and others out of CHOP are talking about the 4 domains of what they call STEM, so related to telemedicine. So they look at the 4 domains as health outcomes, health delivery, individual experience, and then program implementation and key performance indicators. And so again, this is just another way to kind of think about things scientifically and try to gather some consensus around, what really is quality when it comes to telemedicine. And what, are we after, the outcome of a mortality, what are the delivery pieces, what are the individual experiences, those kind of things. So again, it's a great study. I won't go through it today, but certainly something that you can, again, use as another tool to think about quality within your own practice or your own institution. Next slide. And here's where I'll stir the pot a little bit, because I love to stir the pot around quality and how we see it, because as you know, in our current environment, access is king, convenience is king, and how many miles you save in getting somebody there, or they were able to see somebody, or they didn't wait very long, or they got the antibiotic, or it saved an ER visit. We often think about things, in those kind of, things that are easy to measure, but I think Dr. McConnaughey out of Rochester Children's really hit the nail on the head with kind of thinking about this. How does trust factor into quality? So in his words, one essential determinant is communication delivers valid information, does so in a manner that promotes trust. As we know, trust is key around vaccination with COVID or with other things, but how does how does trust impact effectiveness of care? So satisfaction, reduction in anxiety, compliance with interventions, recommended, likelihood that parents will actually contact you rather than go elsewhere. I hear a lot from pediatricians around technology and saying, hey, it's really not going to work because they're just going to go to that convenience store, anyways. And is that on the patient or is that on us and how we kind of build that? Because Dr. McConaughey and his studies would suggest that if we have that trust, it's going to impact utilization. So if they're confident in the care that they can get, they're more likely to come to, seek that person that they trust over and above everybody else. So I'm always intrigued because very few quality metrics, especially around telemedicine, talk about where is the medical home, where is that trusted provider, where is that local hospital that involved in this. So again, I kind of throw that challenge out to you. Next slide. So when I think about this, and we worked with a group many years ago. Rebecca was on a group that we kind of threw out ideas and tossed things around. But, as we think about quality, when I think about it from a broad perspective, certainly from our Anytime Pediatrics perspective, is, how do we improve access to the continuity of care? And what access does that patient have to that continuity of care? To me, that's critically important. Certainly cost of repeat visits. We see kids that go to retail clinics and ER visits all the same night, in my experience. And what is effectiveness, right? Is it adequate care? Is it enough? Or is there other things that go into that? Patient experience. And then, the National Quality Forum brings in clinician experience, which I think is critically important too. It's something more that we could talk about. But enough about kind of the broad brush overview. My goal in the intro here is to kind of confuse you as much as explain things, because I think overall what you'll hear today is different perspectives from different folks on how they look at quality metrics, what they can measure and what they would like to measure. And so we'll kick it off with Rebecca Ohlinger, who's the virtual care manager of Omaha Children's, and found herself in the hot seat in March, even though she'd been working for years on trying to get folks to utilize telemedicine in their practice. And going that way. So Rebecca, we'll turn it over to you. Let's see.
All right, can you hear me now?
Yes, we have you. Perfect.
All right, when she switched the control over, I was still on mute, so I wasn't sure how to go about doing that. So thanks, Mick, for the invitation today to sit on this webinar and talk with you all about metrics. As Mick mentioned earlier, a few years ago, he and I and a few others from around the country kind of started to get together to talk about what are metrics in virtual care. What do they look like? What can we measure right now? What means do we have to measure that? And, I think everybody always has that would like to column. And then what does that look like? How can we centralize some of this data to start making sense from a benchmarking standpoint too? When we say patient satisfaction is 85%, is that good? Is that bad? Should we be aiming higher? Should we be aiming lower? What's a benchmark for pediatrics? There's a lot of really good data out there for adult care, but when you specifically look at pediatrics, we kind of live in a little bit of a different world. So just to share a little bit about children's and our journey. The slide that I have here, these are the current quality metric areas that children's is capturing. And I'll share just a little bit about the history of our program at Children's. When I started back in 2018, we had a largely a robust program for behavioral health. Of course, that was trying to grow. We were trying to drum up more interest from other specialty areas and primary care. And it was challenging. I think everybody's familiar with that bell curve of technology adoption. You have your early innovators, and then you have everybody else in the middle, and then you have the resistors on the other end. And so we were trying to get across that chasm to get some more interest, which means more data to show that there is quality that can be delivered, quality care that can be delivered with telehealth. 2019, we grew from 1,800 visits to 2,300 visits. And then much like the rest of the country, the public health emergency hit, and our program growth was about 2,000% In 2020, we hit almost 51K visits. So the areas that we're looking at, and as Mick mentioned earlier, there's kind of a few different approaches that you can take to metrics. Where we have landed right now with what data we have to measure is just general program performance. So looking at things like, how many visits are we doing, and in what buckets are those falling? Are there any trends that are alarming within those areas? So such as behavioral health, primary care, specialty care. We also have rehab doing a considerable number of visits as well. How many of those patients are new? How many of those patients are follow-ups? So those are some of the areas that we're capturing there. Provider measures, common sense, usability. Did you feel like you had adequate support? How do you think the patient felt about their visit? And this is interesting because we asked the same question to the patients. And then when you compare that same question side by side, for example, if a provider says, I think our data showed 75% of providers thought that the patient felt that the overall visit went well. Then you look at that from the patient side, and the patient said, well, our satisfaction with the visit was about 97%. So very different data, but when you dig down further into the comments with regards to that question, the provider will often say, well, I thought it was less than optimal because maybe the patient was on mute. And we had a little bit of challenge, in the beginning getting connected. But the patient didn't think it was a problem. And so there's a disconnect of what's actual quality, where the patient felt like, oh, it was no big deal. Yeah, I was on mute. The provider thought maybe it was a less than optimal experience for the patient. And so it was just really interesting. That was one of the interesting points that we found in some of the data as we started sifting through it, that the patient experience was higher than the provider experience. And the provider experience rated the patient experience less because of some of the little technical nuances that might happen there. So just interesting to find that out. We also look at work-life balance. So has telehealth helped providers feel like they have better work-life balance? Now that you're able to work from home, see patients from your office, those kinds of things, do you feel like that's been improved or lessened? And right now, I think it's about 20% of providers are starting to feel like that's maybe kind of helped their work-life balance. So that's interesting too. Patient measures, of course, access, right? Access for the patient, access for the family, access for the care team. We have, Nebraska is a pretty rural state where it takes about 8 hours to cross the state from the east side to the west side. So, just looking at that financial impact, looking at how we're getting reimbursed, and then we do follow the marketing trends as well. So here are our quarterly trends for 2020, and you can see primary care, specialty care, and behavioral health listed here. And I think, the trend, and Mick and I had talked a little bit about this too, just about what's the national trend look like as compared to kind of individual health system trends. And are we close to that? Are we following that? And I think for the most part, you can see behavioral health was kind of the exception here. But for the most part, everybody kind of started low, we peaked. In the middle of the pandemic, I think when things kind of started to calm down, school let out, summer hit, nice weather, you started to see that dip and then another peak again. And now I think we're starting back down and we'll eventually kind of find our sweet spot, as I like to say, as to what does our hybrid model look like at Children's Hospital and Medical Center. Another thing that we thought was interesting, because we are such a rural state, is I wanted to look at the data for the miles saved by our patients. And you can see here, so this is minimum miles saved for our patients that had telehealth visits in 2020. And, Mick had mentioned, I think we have to be careful to not make it be all about convenience, but convenience does matter, especially when you're in a state where there's limited specialty providers and they all live on the east side of the state and you're in the west side of the state and it takes you 6 hours or more to cross that, that barrier. So minimum mile saved here, which was pretty considerable. Urgent care, I think we'll see that go up. But we did, and the reason that I think that that's a little low is we did not implement virtual urgent care until late this fall. So I think those numbers will start to climb, but that's pretty considerable. And then the cost savings that you can think of that is associated and goes along with that as well. And then looking at primary care. So we are doing virtual visits for primary care. And I look at the data and share this with our primary care providers and kind of let them sift deeper into the notes here. But you can see, here's our top 10 reasons for telehealth visits in primary care. You know, at if you turn the next page to 11 to 20, there were a lot of rashes, insect bites, things like that, which you see peaks during certain seasons. But a lot of screening, a lot of behavioral health pieces, and then your basic, you know, cold, fever, sore throats. So I will pause there and let any of the other panelists or Mick, if you have any other questions about any of the data that we have been capturing at Children's, if you guys want to ask anything about that.
Yeah, no, Rebecca, that was great. A good overview of kind of the broad brush that you guys take. I am curious, just as a quick question, when you show those primary care numbers so much lower than the subspecialists, do you look at visits per provider? Do you have a lot more specialists? Is that why the numbers are so skewed? Or is it because there's something else? Is primary care more reluctant to provide telemedicine?
Yeah, you know, when I initially started in my role, as I mentioned, you have that bell curve and they kind of fell in the middle to the resistors. Just really didn't see a place for virtual care. They really weren't sure where that existed. The very few visits that were being done were behavioral health visits. So we've had to work really hard to have those discussions. Of course, our current pandemic really push that forward and push that adoption forward. So I think there's a lot more buy-in there, but I think it comes back to, you know, something you alluded to earlier, Mick, and that's the trust. There's still a lot of providers that feel that maybe that level of trust isn't there over Zoom or whatever platform that you're using. And they feel that that in-person visit is still that maximum level of connection and trust that you can have with the patient. And I think that is the big resistor and the reason why people just would rather bring them in. And I think that message, you know, when the provider feels that way, the message gets to the patient that way as well. And I think it's just going to be really interesting to follow those trends after we come out of this and see, is that really still true for the patient? Has the patient started to realize, well, during the public health emergency, you could see me for this virtually. Why can't you now? And I think it's going to be really interesting to see certain populations of people maybe push back a little bit against the providers to say, well, I thought it was adequate. I thought it was quality. I felt like I was well taken care of. Why didn't you? And so when does convenience trump trust? And when does trust trump convenience? And where is that sweet spot? And, you know, maybe it will be that our primary group meets our patients halfway and they say, you know, for well checks and those instances where we have to get our hands on you, we'll bring you in. But for everything else, you know, we feel that we've got data and maybe it's going to take going through charts and notes and looking at outcomes and looking at diagnoses and things like that to really prove to them that it is good quality. I'm not sure what the answer is there, but I think we'll get there. I think it's just going to take a lot of those good conversations to have to break down and continue to break down some of those barriers.
Excellent. Thanks, Rebecca. we'll take the time now to turn it over to Indira from Allied Physicians Group. So it's great to kind of get the comparison between primary care and specialty care adoption. And then within Indira's role as the Director of Analytics at Allied, she's really dealing with a large super group of different pediatric practices that have all approached kind of pediatric telemedicine differently. And look forward to her sharing her insights with us. Indira, I'll turn it over to you.
Thanks, Mike. Yeah, so like you said, I work for Allied Physicians Group. We're a partnership of about 150 clinicians in over 30 locations across the greater New York City and Long Island area. So definitely diverse population, a lot of different practices and provider types. So, oh, there we go. Okay. So I don't want to reiterate what Rebecca and Mick already said about defining quality, but we have the three main players here. We have our patients, who really are the center of our business. We have our providers, who are providing the care and services, and we have the insurance carriers. And for us, Allied has always been a very data-driven and quality-driven organization. So patient-centered medical home is kind of the gold standard for what quality is. So I'm going to kind of talk about the different principles that we have listed here and how telemedicine actually helps us achieve the goals of PCMH. So the first principle we have here is team-based care and practice organization. So because we're remote, we really have to come up with processes to ensure proper handoff of patients from an after-hours provider to the daytime provider, or whether it's from the staff to the on-call telemedicine provider. So we really have to utilize the EMR and communication and make sure that it's very tight across all different staff types. Next is knowing and managing your patients. So we're able to also look at diagnosis codes. This is just the top 3 diagnosis codes that were built out for telemedicine visits in the past year. And this allows us to really provide condition-based proactive outreach. So from an Allied perspective, even though we're mostly pediatricians, we have auxiliary services such as breastfeeding, asthma, mental health, nutrition. So we've been able to kind of see what are our patients coming for, what's their need, and how do we get those patients back in utilizing telemedicine. The next principle of PCMH is patient-centered access and continuity. So we found that about 70% of our telemedicine visits are booked within 24 hours of the actual appointment type, compared to about 30% of a traditional in-office visits. So we're able to provide same-day visits for patients where they might not have otherwise had those with in-office visits. And you can see that the non-telemedicine visits are scheduled further out. Those are typically our well visits, not our urgent or sick visits that the telemedicine is typically coming in for. As pediatricians, we know that after school hours are prime time for our offices. So you can see here that telemedicine visits primarily occur after hours compared to traditional in-office visits, especially when you look at, after 7 p.m. That's majority of those are all telemedicine visits. Providers aren't seeing patients in the office at that time. Another benefit of telemedicine regarding patient access is that it allows us to push patients towards other technology. So for example, when you're in the office, your patient will get an out of school letter or a printed copy of their vaccine record or a lab result, something like that. With telemedicine, we're able to direct them to our patient portal and utilize technology in that way as well. So even though it's not directly related to telemedicine, it affords us that opportunity to make them utilize all these technology platforms that we have available for them. And additionally, since there's typically no formal checkout process for telemedicine, whereas in the office you have a checkout desk and the patient comes in and the receptionist will check them out, schedule their next appointment. We can also push them to use our online scheduling option as well. And that also saves our receptionists some time because they're able to work that list of online scheduling versus having to pick up the call and then try to direct it from there. So as Mick had said, we also want to be able to measure the trust. So for us, we want to understand how many of our patients who are coming in for telemedicine for the very first time are going to come back to our practices. So we found we were getting lots of new patients. You can see here the practice number 1, they got about 30 new patients, and 19 of those patients came in again for a repeat visit. So that was a retention rate of about 60 patients. And for our entire organization, we're at a retention rate of about 60%. So that means we have a patient who came in as a new patient for telemedicine, and they decided they like the practice, they like the provider, and they're going to come in again, whether it's via telemedicine or an in-office visit. Next, we can also measure our net promoter score, measure patient experience through net promoter scores that we get through post-visit surveys. So you can see here, the telemedicine NPS scores are pretty much identical to any type of in-office visits. Whereas the content of those might be different. They might enjoy one aspect of it, not the other, but the overall satisfaction is about the same. And you can see here with the comments, they find it convenient, easy to use, quick, safe, timely, and they're willing to do it again, which we've seen in the data. For the provider experience, we don't have a formal survey for the physicians, but anecdotally, we found that many of them also find it easy and convenient. And like Rebecca had mentioned, it allows more of a work-life balance for our physicians. Mick had mentioned as well earlier that we have very different provider types and preferences when it comes to telemedicine. So for our providers who may not necessarily be as enthusiastic about moving forward with telemedicine, we're able to actually show them the benefits of providing these types of visits. So this first set of columns shows our visit volume this year compared to last year. And anything that's highlighted in green is doing better than the allied average. Anything in red is doing worse. So you can see here this top practice, they're doing pretty well compared to the rest of the organization. They're down only about 5% for the month. If we look at their telemedicine, they're doing about 1/3 of their total visits via telemedicine. When you look at these practices down here, practices 14 and 15, you can see they're red. They're doing much more poorly compared to their colleagues. They're down about over 30% compared to last year. And their telemedicine is only making up 1 to 2% of their total visits. So this is kind of an example that we can take to our providers and say, hey, look, if your volume's down, you need to do more telemedicine. It's proven that it's going to help your volume. And then this brings us to the final player that we were talking about, the insurance carrier. So we're looking at the correlation of visits to payments during the same time frame. Payments is that light green color. So you can see we're pretty much mostly paid through for dates of service through 2020. We have open balances for this year, which is expected. And if we want to delve a little deeper here, we can compare what the payments we're receiving for in-office visits compared to telemedicine. So I don't know if everyone can see it, but we're comparing E&M codes here. So 99212 through 5 for in-office visits by payer, and then the same codes for telemedicine by payer. And here, this difference column shows us what the actual payment difference is by payer. So you can see here for this particular carrier, it's Aetna Medicare for 99213, there's a difference of about $6. So telemedicine was getting paid $6 less compared to the in-office visits. This was kind of a bigger deal in the beginning of the pandemic because we were trying to understand how the carriers were going to handle payments, because from our provider's perspective, they're providing the same level of service. So we were expecting to be paid accordingly. And as you can see, the numbers are pretty close. We are getting paid the same for telemedicine and in-office visits now. So I think a lot of this data shows how the telemedicine program is beneficial for our patients, our providers, and the carriers also see the value in and are reimbursing us accordingly. So as healthcare evolves, I think there's going to be a lot more quality measures surrounding telemedicine. Thank you for your time.
Indira, that was great. Really appreciate the overview. I can't imagine that many practices have that level of data and detail to be able to kind of drive. How do your discussions go with pediatricians that are light on telemedicine and are hurting more? Do they recognize the data, and does that influence behavior, or do you find that they're kind of dug in?
I think it depends. I think a lot of people are stuck in their kind of in their ways, so it's hard to change. But I think, I mean, the data does speak for itself. So I think if they come to us and are looking for solutions, we can provide this as solution. But we can only do so much. We're still allowing them to kind of manage the practice the way they would. So.
Yeah, and then can you clarify that for the group? So you mentioned that new patients, are these new patients that are coming into kind of your virtual urgent care that you all have after hours, or are these new patients that are scheduling a visit but doing them first via telemedicine and then coming back?
It could be either or, yeah, either of those options. So it's not necessarily just, it could be maybe sometimes they do, they could just call in for a sick visit and they schedule them as on telemedicine, or like you said, it could just be after hours where they kind of utilize it as an after hours center instead of during the daytime, or instead of going to urgent care.
Okay, excellent. Thank you for that. And now we'll turn it over to Dr. Russell Libby, pediatrician du jour out of Virginia Pediatric Group. I think he's, I don't know if he's in Virginia. I think he likes to spend most of his time out in Colorado and watching the blizzard snowfalls and skiing through them. But another innovative pediatrician, certainly on the early adopter side of telemedicine, and does a lot of interesting quality work nationally. So Russell, we'll turn it over to you.
Well, thanks, Mick. And it's really great listening to this information and just realizing how much data is accumulating so quickly, yet we don't even know how to sort it out or make meaningful use of it, not in terms of CMS, but in terms of just being able to apply it and understand how we can move forward. Yes, COVID gave me the opportunity to implement telemedicine in the biggest way possible, and has allowed me to stay in the mountains a lot more than I might otherwise have been able to. But nonetheless, it has also stimulated a lot of activity around this whole topic of telemedicine, and certainly to think about how we can integrate QI, quality improvement, into the telemedicine work that we do, as well as integrating telemedicine into the quality improvement projects that we take upon ourselves in our practices is essential. When we look at how docs respond to it, I remember when I first heard about PCMH, and I thought, well, if I can qualify for better payment, I provide great care, I can tell you, but most of the payers said, no, you better make sure that you do the qualifying measures and you get certified. And so that set me on a process, taught me a lot about this. I know our older docs all thought, they practice quality medicine, and there's no question younger docs have had the experience of working in systems where they understand QI, understand how to set up projects. And thank God we had younger docs in the practice to help us do that as we moved through this. And of course, now, if you want to stay certified, you have to do MOC4. So you have no choice but to understand and implement QI in your practice. So as we see here, QI for the pediatric practice, certainly there's no margin and no mission. If you can't find a return on investment on making improvements and demonstrating them, then you've got some questions to answer. It's not an easy outcome if you aren't doing something that helps make it possible to stay in practice. We don't have huge margins. And I'll tell you, looking forward from what we've been through and how the practice of pediatrics has changed, in particular for primary care, we have some things to find out over the next 6 to 12 months. But we're continuously doing things subconsciously. Our operations are always redesigning themselves to improve workflow, to know how to use staffing more appropriately, to designate responsibilities, and to build the culture of that practice. We do this passively. And as we've been mentioning through all the course of these discussions, PCMH, patient-centered medical home, has been a way that we were able to demonstrate and actually quantify that improvement and see and learn how to compare what we do, the processes, and how we make them better, and how we can demonstrate that to create value. And that value comes back sometimes in enhanced fee-for-service contracts, shared savings through specific types of contracting that might go through an IPA or an ACO, and to basically to be able to generate that kind of opportunity to capture more revenue based upon you improving the kind of care that you provide and to demonstrate it. Of course, you have the traditional payer measures. They're all going to want to find ways to encourage you to provide them data that they can use to create the value around their plan. That's HEDIS, CQMs, continuous quality measures. These are all the kinds of things that they are measured by. So we reflect their quality, and they need our data to be able to demonstrate that, to get certification as well as better funding through government or other programs. And of course, then we have all those public programs that are all around quality, and most of them are generated by the public payers like CMS and Medicaid, but there are those that support those efforts. Those are the NCQAs and other kinds of things that we observe. I guess you can go to the next slide. So when we think about those programs, and I won't dwell too long on it, but there is what we call the EHR PQRS. That's the Physician Quality Reporting System. Some EMRs can actually develop and devise ways to be able to report quality improvement through their data production, and they can qualify, and that does elevate them as a EMR, makes them more attractive to us as well as to other kinds of qualifying organizations, elevates them in the image of those who evaluate EMRs. There's CHIPRA, that's not CHIRPA, but CHIPRA is the Children's Health Insurance Program Reauthorization Act. What you might remember really did a lot to improve access to care for kids, and reassured us. And in that are a long list of quality measurements and quality improvement activities. And most of that is stewarded by the NCQA, the National Committee for Quality Assurance, which is pretty much the standard for us in developing how we demonstrate our quality, and that holds us up to certain standards, and is currently working on new standards around telemedicine. And of course, CMS, Medicaid, the Maternal Child Health Bureau, and Health Resources and Services Administration, they all are very important relative to generating quality concepts and how we will work with them. The AMA, the AAP have their programs that help us. EKIP is of course the one that we use for our MOCs, but also end up qualifying us for a lot of the certification that we need. And our specialty orgs may provide some of those. But you know, when we look at quality measures, we want to make sure they have meaningful impact, that they have to help the practice and especially help the patient. They need to be easily integrated into our day-to-day practice and our workflows. They have to be scientifically sound. They have to be in concert with our clinical guidelines. But once again, it's the families, it's the patients that need to be served by these, and hopefully it'll improve the way we practice and create value that we can be rewarded for. Next slide. So as we know, there are those types of measures, and this is not new to anyone, but there's condition-based or clinical process and effectiveness-based, whatever you want to call it, that might be doing a strep test when you prescribe antibiotics with a pharyngitis diagnosis, or screening for chlamydia in adolescents who are sexually active, et cetera. You have the preventive care and population health-based measures. Those are on our well child care, weight assessments, counseling, immunization status, developmental screening, all those kinds of things. Next slide. But the issue is, how do we develop and demonstrate quality for getting rewarded in telehealth? Now, you know, certainly there was not much data on telehealth rolling into the March of 2020 timeframe. But then since that time, the amount of data is unbelievable. I mean, it's almost overwhelming. It is overwhelming. And as we saw all of those regs and payer restraints relieved, and currently still are in most areas with this public health emergency, there was really, it sort of turned patient visits into the Wild West, where you could really pretty much do it however you wanted, whether it's by telephone, by FaceTime, by Zoom, or you could use a qualified and really specific telemedicine platform. Most of the information we have on telemedicine is going to be retrospective now, not prospective. We're trying to find meaning in what we did, not necessarily create meaning in what we will be doing. We certainly have payers who have a lot of data, but not all of it is accurately represented because so much of it goes into the system as in-person visits now, and we don't really know if they're going to be forthcoming. They've done very well with us using telemedicine as an alternative strategy for care. And then, of course, if your EMR can integrate telemedicine and understand how to extract the data around telemedicine relative to the use, relative to the outcomes, referral patterns, all the kinds of things that we're going to be using for measures, that would be really helpful. But I'm not sure that the majority of EMRs that pediatricians use have those attributes, but it is something that we're hoping we can see built in. And as the regs change and whittle down, people will be forced to make a decision as to how they're going to choose a platform and how that will be integrated into their day workflows in their EMR. Next slide. So when we look at those quality measures, we think about really what matters to the insurance companies, and that's going to be outcomes, downstream costs, and what are they going to be reflected in? Reduced ER admissions, better access, more hours, reduced testing, unnecessary procedures, and referrals. And I think that we've been able to improve compliance in a lot of diseases that we treat, conditions that we monitor, by virtue of being able to access the patient access us in a more convenient and doable setting through telemedicine. And we're going to have a lot of data to support this. The insurance companies have had their best quarters in the history of the industry during those first 2 quarters that we had COVID. The amount of money that they retained is incredible. And you'd think that they would be really adamant and exuberant to continue to support this. But there's going to be some come up and at some point, some kind of reconciliation, and it may involve having to do things like certify that you are a patient certified telemedicine home, et cetera. But we'll talk about that in just a minute. We know that we have lots of measures that we measure quality in our own practice with, be them the MOC or PCMH type of measures that we have to demonstrate value for and compliance with. Can we extend those into virtual visits? Well, some of them are amenable to that and some are not. And once again, the telemedicine certifying programs you're going to see through the American Telemedicine Association. NCQA has just finished working with a large work group to look at actually certifying the telemedicine patient-centered medical home. That is going to require you to be a PCMH certified environment in the first place before you could even think about using telemedicine for that. We have a lot of interest in the AAP and the chapter quality forums, and our EKIP and MOC projects are probably really ripe for development of creating some data and some opportunity to demonstrate this quality improvement endeavor. Now, one organization that I work with, next slide, is called Sprout. Sprout is the Supporting Pediatric Research and Outcomes and Utilization of Telehealth. And it's basically a multi-centered collaborative research network that is really dedicated to supporting efforts to create an evidence base for pediatric telehealth services. Now, what that mostly means is that we want to support the adoption of telehealth, and we're going to help provide education, develop best practices, and try to create resources that can help us as practicing pediatricians do it. And we want evidence. We want to create evidence that there are best practices and you can demonstrate quality improvement through using telemedicine in your practice. In Sprout, we have what they call TWIGs or TWG. Those are topic working groups. There are 6 topics. The one of which I'm involved with is called the PCMH TWIG. that is all about being able to convert some of the measures that we use into meaningful QI endeavors for the practice. What we're working on now is taking an EQIP and NCQA quality improvement initiative on ADHD medications, and that was basically a 30-day window within which you see a follow-up on a patient after initiating or changing your ADHD medication. It's not an easy thing to do when you're doing it in person, but we feel that this is a great spot to start with telemedicine, and we are currently working on developing an MOC module that we could use through EQIP and get NCQA to adopt, so that we can use this moving forward, create a database, and start to establish the value that we are looking for. So, and I don't know, is there another slide? Yes, quality data is essential. There's a lot at stake here. I think telemedicine has provided us a way to augment our care, not replace our in-person care, but to really create a rounded practice. Patients want it. They really like it. I've had incredible feedback and a great experience doing telemedicine, and our doctors need it. There are many who are at a stage where they don't necessarily want to be in the office, where they could be retiring, but may want to spend a couple of days a week seeing patients and continuing to operate. There may be postpartum moms who are willing to work 4 or 6 hours in the evening, 3 days a week. Whatever it might be, it's remarkable what the opportunity creates for us, but we need to sustain the revenue that we get from telemedicine. We need to advocate for it. There's a lot coming up that we need the data to substantiate and support our efforts to do this. And ultimately, it's good care. Patients want it, and it really works. So thanks, Mick. Thank you all for your great information and good stuff.
Yeah, Russell, it's a great perspective. So in your personal group, where do you think things lie as far as adoption from telemedicine standpoint? Obviously, you're almost 100% virtual now, and how
Yes.
do your other folks see that and see that as part of their practice and integrate kind of in their in their daily routine?
Well, let's say there are a lot of docs who still practice in the 20th century. This is how I generate revenue. I touch the patient, and that's the only way I have a quality interaction. I would beg to differ. I'd say that the quality of my interactions and the energy I give and get from a telemedicine interview and encounter is equal to, and sometimes even greater than I can get in a patient room. There's no screaming babies down the hall. Every now and then someone will scream something at me, not knowing I'm doing one, but otherwise it's remarkable. So in terms of my practice, I think this is a permanent part. We had started initially with this for our neurobehavioral and other kinds of simple screening things that were not paid for. The opportunity to get paid for things that we did for free through advice lines or after hours responses, et cetera, now gives you that opportunity to actually get paid for the professional work that you do. So I think that it's going to be a part of revenue. It's going to be a part of operating. And if we don't figure out how to make that happen, many practices will not survive this next year or two, because infectious diseases are there, but they're not going to be in the office the way they were. And we've seen actual studies that have demonstrated that over the last 10 years, the volume of those visits has gone down 15 to 20%. And it's going to continue to go down. I know in my practice, it's probably down 80% relative to other years, but it's exceptional. But nonetheless, I think it's a real part and a regular part of practice going forward.
And one other question for you, Russell. You kind of presented the vegetable soup of what I call, quality metrics and quality measures, right? So here's, CHIRPA, CHIPA, CMS, HEDIS, who knows what, right? But how does someone that runs a practice like yourself narrow that down to kind of a plan, do, study, act kind of quality improvement program? Sounds like you pick something like ADHD. And you're able to iterate that, give that. Is that really what you would recommend to other practices? Is pick something, share that data with your group, and kind of continually iterate on it?
Yeah, I think from my Sprout point of view, what's clear to me is that you have to do something that has more than one objective. So if we have MOC and we have to do QI and we want to provide telemedicine services, it's something that if you can build it into a queryable database, you can extract the information you need to improve your quality and demonstrate the benefit and capture some value from it. So I hope we can do that with other things. I truly feel that the majority of sick visits that I would see in my office, I'd say that 80+% of kids over the 40 years of practice that I would see in my office didn't need to be in my office. But there's this sort of agreement between triage and practice revenue that this time of year people want to be seen and have you look in their ears. Well, really, I think we can do a lot of this through a virtual interface, save people a lot of time, effort, and consternation, and augment what we do in the practice so that we're more focused on the things that do require a hands-on or a face-to-face. It's going to settle out. I'm not sure where it will go, but right now I'm enjoying this transition.
Yeah, great perspective. So folks who want to put in questions, I know we've got a couple, one in the chat, one in the Q&A. Certainly feel free to do so, and we'll kind of relay these on. So I'm with you, Russell. Obviously, I'm biased as an ER doc more than anything, because I'd say 80% of what I see are kids that have either come from the convenience side, where they've chosen convenience over trust, or they just don't have access to the trusted care that they really need. Because as you and I know, in clinical practice, 80 to 90% of what I do in the ER is reassurance, right? You're okay, you can go to bed, your child can go to bed, and you wake up in the morning and you can see your doctor, right? If you need to. So it's pretty interesting. So let's go to a couple of questions. Here's some really good common questions, especially when we talk about quality and telemedicine that is often raised. So how do you manage ear pain, dysuria, and sore throat diagnosis and treatment via telemedicine? Russell, I'll let you kind of handle that, since you're sitting in Colorado and seeing patients in Virginia. I'm sure you just write antibiotics for them all, right? You just say, hey, whatever, right?
Right. Yeah. No, the first thing I ask is their pharmacy number, right? No, I would say that, gosh, if I have prescribed antibiotics without a positive strep test 10 times in the last year, I'd be surprised. I think all of us have whittled down our use of antibiotics to exceptional situations. And I think patients have become receptive to that, which has been really important. But relative to vital signs, there are certainly three things you can do. One, we do a triage and introduction with an MA or some other individual in the office to make sure the connection's there, make sure that we have the data that we need on the patient encounter before I actually get on to that virtual platform. So often we'll ask them, get a weight, take their temperature, count their respirations if it's about a suspicion or worry about some kind of respiratory difficulties. If they have ways that they can transmit those, there are some remote systems, TytoCare and some of the others that do create tools that patients can buy and keep at home with pulse ox, respiratory, heart rate, blood pressure, all those kinds of things. But for the most part, I think my eyeballs work pretty darn well. When I watch a kid breathe, when I watch their nose, I see them, sip from a cup or suck from a bottle, whatever it is, I don't feel that I'm easily fooled based upon my clinical instincts. If I am, or I am at all suspicious, I do require that they come to the office or get seen at the ER. So I think that we will see over the next year more access to some of the remote exam tools. And I think that you, Mick, are doing remarkable things to try to create the opportunities and to find ways to integrate that into a record so that it's easy to do and use. So I think that's there, and I'm sure others have other perspectives.
Yeah, I mean, I kind of gave the sarcastic answer because I think people often see telemedicine as, and certainly the study, Kristen Ray, that 80% of kids that went on telemedicine, got or a tremendous amount of antibiotics, prescriptions, and those kind of things. And to me, the interesting part of that study is none of those kids saw their pediatrician. And I think less than 20% actually saw a pediatrician. So we often lump kind of telemedicine all together. It's kind of like, I'm biased. I'm a pediatrician, right? So, and I see what comes from retail clinics and non-pediatric urgent cares and non-pediatric offerings that have all the tools, all the devices, all the strep tests, all the urinalysis, and so many kids still put on antibiotics, even though those things are negative or they don't have something or things like that. So I think for the pediatricians that we see, they don't write a lot of antibiotics. They don't write a lot of prescriptions. They typically bring kids into the office for, what some call a fast pass. I know Indira's group does that, where they bring them in for a urinalysis or a strep. So you can reassure them. I'm always amazed in the ER when I get ear pain at midnight. I'm not sure that dose of amoxicillin I give them at midnight really helps that ear pain. It's probably the Motrin that I gave them that I probably could have given them at home, and they could have been seen in the office the next day. But, I think a lot of that, what we're doing is reassurance, but people have to separate out the technology, because the bricks and mortar don't write antibiotics. Telemedicine doesn't write antibiotics. It's all about who you connect with. So I think that's one of the common misnomers that when folks think about telemedicine in that way. And then,
to piggyback off of what you just said, Mick, I'm going to put my mom hat on here. And, the times that I have chosen convenience, through my own health plan, and seeing a doctor virtually who is not my child's pediatrician, it's been because I don't have that option with them. And so I think that's really the question once the dust starts to settle is, if you don't have that option for your patients, you're going to lose them. Because in certain instances on a Sunday when I'm traveling out of town on a Monday and I need my kid to be seen, I have a convenient option. If my pediatrician had that, I would have chosen to go to a trusted source for convenience versus a non-trusted source for convenience. And so I think that's one of the factors that's really going to play into this when the dust does settles, is that option better be there.
yeah, Indira, I know data from leakage to local urgent cares and the like. Have you guys, and that was a big influence into Allied getting into urgent or a virtual urgent care and offering that if the practices want or don't want, so your patients could stay. Have you been able to recognize an impact? I guess it's probably harder this year with COVID, but you see less of those patients getting, your faxes from, local urgent cares and the like, because you're available?
I think they're always going to go. There's always going to be the parents who are going to go to the urgent care no matter what, because they think they're going to get that better care. I think it's part of it's the trust, but I think part of it is just what they're used to. So I think there's always going to be that subset that's going to go to urgent care no matter what, because they want that hands-on approach. But I think that because we're able to offer like after hours options as well, which we weren't doing before, I think to Rebecca's point, there's definitely those patients who do prefer the convenience, and they know it's not a huge, the kid's not really, really sick. They're not super sick. They just kind of want an opinion from a doctor. So I would say it's probably split.
Yeah, excellent. And I think, I don't know if there's any other questions, Tencel, has any other come in, but, I think there are more to Russell's point. There's more devices coming, portable otoscopes, little pulse oxes, things that are going to lower the cost and the barrier. And also our hope is to obviously expand that kind of reach, across equity, right? So equity is a big part of quality. And I think what we see through COVID and even through telehealth and broadband and is that access. And man, what a great tool technology could be if folks had internet and broadband to be able to reach, their pediatrician, as opposed to kind of taking that quick path to a convenient care that may not give them the same level of care. So anyways, I know we're coming up on time. I really appreciate everybody's time and perspectives. I think the beauty of quality, and I think, Rebecca, I think it's remarkable that patients, 97.5% in favor, and docs are still sitting 75%, which is probably, 65% higher than it was, last year at this time. But I think sometimes we can't lose sight that quality has many levels and many perspectives. So there's certainly the patient perspective, the clinician perspective, and then we have to think, I hope today we kind of triggered a little bit of thought about, how do we foster that trust and where does trust come in to drive quality? So anyways, thanks again for all your time and information, and hopefully everybody out there and who hears the recording finds some value here, because, it's you know, I don't want more vegetable soup, but I want more more good soup that's delivered at home and connected to the pediatrician. So, and I think that'll always drive the best quality. So again, thank you all very much for your time, and appreciate it. And have a happy St. Patrick's Day. Hopefully you get some brown bread or some corned beef and cabbage if you're from an Irish background like myself. So you all have a great day.
Thank you. Thanks, Mick.